What we're going to do in this short time that we have together now is talk about basically some outpatient dermatology. And these are things that are likely to go home. So these are stuff that you may see in the fast track or urgent care. If you see them in the main ER, it's usually because what they've been using at home or what they've been using from their primary care clinician is just not working. So they're either having a lot of pain or extreme itching. Now, patients that have just bad petechiae, multiple ecchymosis, exfoliating skin conditions, all kinds of weird stuff, we're not going to talk about. That's a whole different topic and needs a lot more evaluation. And so we're going to jump right into this. We're going to talk about eczema or atopic dermatitis. Very, very chronic, pruritic skin condition. And a lot of erythema, crusts, fissures, excoriations, lichenification. We see this a lot in infants. Show you a picture in a minute. Mostly of the face and the scalp and extremities. Usually occurs in the first few months of age, and most of the time it resolves by the time that they're 2 years old. With adults, a lot of dryness and thickening, especially in the antecubital and popliteal fossae and neck areas. Usually with folks that have atopic dermatitis, there's a long family history of it. A long family history of dermatitis, perhaps allergic rhinitis, a lot of other things. And it's usually worse in the winter, especially just because of the dryness of the air. Treatment for atopic dermatitis is just basically, corticosteroids, usually over-the-counter, there's all kinds of different kinds of steroid creams out there, both prescription and over the counter, as well as some antipruritics, some diphenhydramine, especially at night. And there are some good prescription antihistamines as well that can be used that work pretty well. Here's a great picture where you see the excoriations and lichenification in the antecubital fossa. You've seen hundreds and probably thousands of these. And again, if you see them, usually you're going to see a lot of this where it's very, very uncomfortable. And usually it's mom or dad that brings in an infant that's just covered with this type of dermatitis, and the kid is just extremely uncomfortable and say, you got to do something for this. We had him in to see our primary care person this week. They said, use the cream, and it's not getting any better. And so now they're in the emergency room saying, help. Here's another picture of an infant. Looks uncomfortable, and usually mom says, mom's uncomfortable because the kid's uncomfortable, and you need to do something about it so that the kid can sleep at night. Here's an adult with the atopic dermatitis. Again, you see the lichenification there, and there's some others, pretty typical stuff. So anyway, the best treatment for the atopic dermatitis, first of all, you need to make sure that you share with the patient, that you care, you understand what's going on with them. I get it that you're itching. We're going to do the best we can, and here's the plan. We're going to try some different kinds of cream. We may at some point want maybe even try some significant antihistamines. Then we go to allergic contact dermatitis. This is something that occurs, a sort of delayed response to something. It's a hypersensitivity to something, whether you've come in contact with poison ivy or poison oak or sumac. Sometime after the exposure, you start getting the symptoms. Happens with metal jewelry, particularly nickel, or hair dyes or detergents. I've seen folks that have dyed their hair and then just broke out all over as a result of that. You usually see a lot of erythema, a lot of itching, a lot of vesicles, especially linear vesicles and bulli. And blisters usually are there. They don't contain any antigen. They're just very, very painful. Treatment for a contact dermatitis, oral corticosteroids for severe cases, or if it's just widespread, if it's just everywhere, you may need to do that. Topical steroids for mild and for limited area where contact dermatitis is. We have a couple of pictures here. You can see that here in this picture, the linear lesion there, pretty typical of a contact dermatitis. Here's another one there, another linear And I think the next one, yeah, is the one with the watch where you can see. So you have to look at sort of the mechanism of the injury, if you will, in terms of if it's contact dermatitis and what the contact is. There's a picture of the poison ivy. A lot of times finding out where they've been. They may not have realized that they have come in contact with poison ivy. Good to know. Moving on to Pityriasis Rosea, the Christmas tree rash. Usually happens in kids and young adults, usually happens in spring and fall. We don't know what causes it. It's not an epidemic, it's not contagious. And the rash actually occurs over a number of weeks. And will actually start off with not a real small, but a herald patch, sort of a single salmon-colored lesion I'll show you in a minute, that's usually on the trunk. It's usually about 1 to 5 centimeters. And it occurs about a couple of weeks prior to a rash, that comes widespread. And so it's important if you see these kind of oval lesions that are widespread. If you don't see a herald patch and the person is sexually active, you may want to go down the road of making sure that there's not a problem with syphilis or a drug reaction. The treatment for this is symptomatic, again with antihistamines if itching occurs. But the truth is, it's going to get better, whatever you do. So you want to make the person comfortable. You can have this as long as 10 weeks. I think there's a picture here. Here you go. Pretty much, this is why it's called the Christmas tree rash, because you get this distribution that comes out. The next one, you can see the herald patch there up on the right side of this patient's chest. It sort of jumps out at you, and I think the next one, yeah, there's another herald patch. So once you see that, you pretty well have the diagnosis. And so that means, you have to look. You need to make sure that if the patient's there complaining of a skin condition, that they ought to be disrobed and in a gown so that you can actually look at the entire body to find out the kinds of lesions that are there. As I said, most of the herald patches are on the trunk, and that's where you ought to be looking for them. Okay, urticaria. This is sort of a difficult concept. In fact, some of the literature I've read recently sort of says less is more when you're treating urticaria. The problem is when someone's in your emergency room and they're swelling and they've got urticarial lesions and they start having some trouble breathing, then we got problems. But generally, urticaria, just a lot of itching. Wheals, hives, and this is a disease of the superficial dermis. We don't know, many times you don't know what the cause of it is. We end up putting down idiopathic urticaria, maybe related to some food or drug, and about a third of the cases that's the case, and maybe even be something that they've come in contact with in terms of stings. I have a granddaughter who has sort of idiopathic urticaria, and the thing that solves it is just persistent antihistamines, both types of antihistamines. In fact, I wanted to get her in and have her tested to do all the skin testing to find out what she's allergic to, but I can't ever get her off antihistamines for enough time to get her tested. And then the question is, what do I do with the answers? Unless she's really allergic to dog or cat or something like that you can really avoid. But nonetheless, these are usually self-limiting for the most part. Severe cases, unfortunately, can cause wheezing or hypotension or certainly swelling of the lips or mouth. Saw a guy once who had been to his primary care office and had his allergy shot, his immunotherapy, and I stayed the requisite 20 minutes. They sent him home, and he's driving home, and he starts getting this little cough. And kind of like that, and then he's noticed that his lips are swelling up a little bit. So fortunately, he stops by the emergency room, and by the time he gets there, now he's itching all over. He's coughing a lot. He's feeling like his throat is sort of swelling up. His lips are all swollen, And so even after the 20 minutes that he waited there, and so it's a good thing he came into the ER. We were able to, and plus he started wheezing, so we gave him the albuterol nebulizer, started an IV, and got him some epinephrine, and it turned it around. But the longer the way he waited, he could have had this at home. But the good news is he also had an EpiPen, but he never carried it with him. So, All right, here's some pictures of some urticaria. We've all seen those, pretty typical. And another large urticarial lesion. And so again, remember, urticaria is a condition of the superficial dermis, and can be mild. In fact, most of these that we see are fairly mild and just require some oral antihistamines and maybe some steroids. As we talked about, like the gentleman that I just mentioned, it can be life-threatening. And so we need to, if that occurs and we start having anything that we think might be causing some issues with the airway, then we've got to get them in. We've got to start the IV. We've got to give them some epinephrine. The dosage is there, you know that, both for adults and for kids. And not only giving it to them now, but giving it to them, every 15 minutes so that it doesn't reoccur. If they're wheezing, using albuterol in a nebulizer form to get that taken care of, and sometimes IV steroids is extremely helpful to turn this around. And it's very important, too, to use both types of antihistamines, both the H1 and the H2. That works really well with urticaria. Okay, angioedema now, a little bit different. Remember, urticaria, superficial dermis. Angioedema is really deeper in the dermis. It's an edema of the face, extremities, the bowel wall, and as I said, it originates deeper in the soft tissue. And interesting thing about this, it is usually no itching, and can result in difficulty to treat. You get a lot of swelling of the tongue, and if you see this early, may need some airway management. So we need to have folks there to be able to take care of that. The most common drug cause of this is ACE inhibitors, and even if people have been on ACE inhibitors for a lot of years, can actually get this reaction. So looking at this early is very important. We may start some anaphylaxis early on, but other therapy may be indicated. So it's important, if we're going down that road, to get other team members involved. Okay, on to other fun stuff, the tinnias. So all the tinnias, the terminology is basically where it's at, whether it's the capitis in the scalp or the barbie in the beard. You can see it all the way down there. Basically, the treatment for this is mostly over the counter with Tinactin or Lotrimin or Mycotin, and they need to treat. The problem with most patients is they don't treat themselves long enough with this, and we encourage them to keep treating it. And I always say, put it on and watch the lesions. And what happens is the lesions just start fading away. And then you got to keep putting the cream on. And you need to even keep doing that after the resolution of the rash itself. And I think that's good advice to give them. Otherwise, they'll just stop it, and sometimes it does come back. Here's some pictures of different tinea lesions. A lot of people think that if you say ringworm, they think it's a parasite, and so you have to explain to them that it's not, that it's a fungus. Tinea versicolor, we've seen a lot of this. These are the hypopigmented or hyperpigmented circular scaly patches. Some concerns about this may occur if there's some poor hygiene or at least a lot of moisture. There's the fungus that causes it. This can be, a person can have this for a long time. In fact, there's some people that may have it their entire adult life. The treatment for this is fairly simple. It's the selenium shampoo or the ketoconazole shampoo or cream. You've got to keep doing it. Unfortunately, once they stop that, many times this will come back. Okay, Lyme disease. Well, we used to say, hey, we're in Las Vegas, we don't have to worry about Lyme disease. But the important thing now is that the world has shrunk so much that it's so easy to get from New England to Las Vegas that we have now seen diagnoses of Lyme disease in every state in the Union and many overseas countries. Transmitted by tick bite, but it may not even have gone noticed. Patient may have come in just because of a large rash. The initial phase of Lyme disease is the Erythema migrans. It's an annular expanding erythematous lesion with a central clearing in there, and it spares the palms and soles. And there's a good picture in your book. It's too bad it's not in color, but I think you've seen these before. So that's the initial phase. The secondary phase is more neuro and cardiac and musculoskeletal and more concerning. The diagnosis, blood test with an ELISA screening and our Western blot. And the treatment for this is doxy or erythromycin, amoxicillin, or ceftriaxone. But here's the important thing. If there's a probable risk, you know, if there's a distant thought that this might be Lyme disease, then you probably ought to test them. But if you have a pretty good sense that this is what's going on, particularly looking at the lesions, then I say go ahead and treat. Here's a picture of the lesion it looks like a big target. I think there's another one coming up here. You can see that. I think there's one more. Yeah, there's another one. You know, pretty much you see this, have a huge suspicion of Lyme disease. Okay, on to other viruses. Herpes labialis, HSV1 and HSV2. Usually one is oral and two is anogenital. This usually involves fever, sore throat, swollen glands, but the thing that occurs mostly is just pain. We've all either seen people who've had this or had it ourselves, where it's just very painful, and then it crusts over, and then you worry sometimes about a secondary infection. And then reoccurrences are extremely common, and the treatment for this are antivirals and starting them early. There's some pictures of the herpes labialis. They just look painful when you look at these. Now, herpetic whitlow, another herpes lesion. These are scary, and the reason for these are a bane of our existence in hospitals. When I used to work in employee health at a hospital, we were really afraid when we had an outbreak of herpes whitlow, particularly among nurses in a neonatal unit, because of the contagiousness of this. It's very painful. About 60% of these are HSV1, and it's on the fingers. Frequently seen in healthcare workers and dental workers and kids. A lot of vesicles there. Don't open them up. This can last for weeks. The treatment is the antivirals. Unfortunately, these people need to be out of the workplace, particularly if they're healthcare workers or dental workers, because of the contagiousness of it. Okay, herpes zoster. We've all seen this. You know, a reactivation of the chickenpox virus. Very painful vesicles in the dermatomal distribution. Years ago, when I used to do martial arts, I got home one day and I thought maybe I got kicked in my back because it was kind of aching back there. And then the next morning, the sort of aching was coming around. And so I went and looked in the mirror, and sure enough, here's this vesicular distribution coming around here. And then it got so painful you couldn't even have a shirt over it because of the pain. And it just lasts. It can last from days to sometimes even weeks. The problem with some of this is if there's a cranial nerve involvement. I saw another patient just recently, a 70-year-old guy who had these vesicular lesions around his ear, actually went into the ear, and then came down to the tip of his nose, and then back up around into his eye. He ended up in the hospital, and that was probably 6 months ago, and to this day he's still having significant optic involvement as a result of that. The Ramsay Hunt syndrome, it's called, with cranial nerve 7, can cause facial nerve palsy and significant ear pain. Some of the complications of zoster: pneumonia, meningitis, post-herpetic neuralgia, all kinds of secondary types of infections. Treatment: early acyclovir and even prednisone to reduce the inflammation. I think there's some. Yeah, here's some of the images. Here's the Hutchinson sign, the vesicular lesions at the tip of the nose. And here's the Ramsay Hunt syndrome I was just talking about. These can just look terrible. Obviously, because they're on the face, they're very noticeable. Okay, here's a distribution that you've all seen in terms of the zoster. Okay, some more of that. Yeah, very, very painful. And I've seen it where most folks have had a very mild case of it, all the way up to very severe case. All right, that was general dermatology in a short period of time. Thank you very much.